Welcome back. This is the second part of the video on Peng block. I hope you have seen the first part of the video. There is a link in the description. Please go and watch that video for better understanding of this video. So let's proceed. We will see the SONO anatomy and technique of giving Peng block. For scanning, patient should be in supine position. If the patient is in propped up position, make the bed flat so that we have better access to the area. If the patient cannot lie supine, we can make the whole table head up position, that is we can give a reverse Trendelenburg position. And now thigh is kept neutral with slight abduction if possible. Now coming to ergonomics. Always adjust the patient's bed height in such a way that you can give the block comfortably. For this, what is advised is the patient's height, that is the anterior superior iliac spine of the patient's body, should be almost within 10 cm from your elbow level. So at this position, you can easily give the block by comfortably holding the probe, and that will improve the visualization of the needle and it will improve the success of the block. Now we stand on the side to be blocked and the ultrasound machine is kept on the opposite side. For scanning, we use a low frequency curvilinear probe because most of the time the area of interest is very deep. Sometimes in very lean patient, or if you are giving in a pediatric patient, you can use a high frequency linear probe as well. Coming to the scanning technique, palpate the patient's anterior superior iliac spine. Then keep the probe, whether you are using a high frequency or a low frequency probe, keep the probe over the anterior superior iliac spine such that it is in the middle of the probe. And the probe is kept in a transverse position. And when I am keeping, always I keep the probe in a way that the marker on the probe is on the lateral side, so that every time you scan you get better understanding of the anatomy, and if there is some difference with the anatomy you can easily make it out. So always keep the probe transverse over the anterior superior iliac spine with the marker on the probe on the lateral side. Now in the SONO anatomy, in the ultrasound image, you can clearly see this classical description of anterior superior iliac spine, which is our first mountain. This is almost the same description which we have seen before when giving the suprainguinal fascia iliaca block. So this first mountain, that is the anterior superior iliac spine, you can see the hyperechoic line with the acoustic shadow beneath it. So once you identify this structure, what you have to do is that you have to rotate the probe in such a way that the probe will lie parallel to the inguinal ligament. So how you will rotate the probe? If you are scanning on the right side, you have to rotate the probe almost 45 degrees in the clockwise direction, and if it's on the left side, you have to rotate it on the anti-clockwise direction, again 45 degrees. So now you have kept the probe almost in a plane parallel to the inguinal ligament. So once you have identified the anterior superior iliac spine, once you have rotated the probe parallel to the inguinal ligament, next step is to move the probe medially along the line parallel to inguinal ligament. So when you come medially in a line parallel to inguinal ligament, the next important structure which you should see is the anterior inferior iliac spine. This anterior inferior iliac spine is seen as the second mountain, that is the hyperechoic line with the acoustic shadow beneath it. Now come further medially so that you can visualize the iliopubic eminence of the superior pubic ramus. So this white hyperechoic line is the iliopubic eminence. So this is the area of importance. If you are not seeing this white hyperechoic line clearly, we can do a little bit of tilting movement of the probe. As I have shown here, this is the tilting of the probe, and this tilting movement of the probe will help you visualize the iliopubic eminence. Or else you can apply pressure on the probe so that you can see the white hyperechoic line more clearly. In case, despite doing the tilting movement, if you are not seeing the white hyperechoic line, there are two possibilities. If either you are more distal or you are more proximal. If you are more distal, definitely you will be seeing the head of the femur with the hip capsule. So in that case, we have to slide the probe more proximally. If you are more proximal, then in that case, the white hyperechoic line is not seen, or the hyperechoic line is seen very deep. So in that case, you have to slide the probe more distally or more caudally. So make sure you are always seeing the white hyperechoic line very clearly. So this is our target region, iliopubic eminence. Make sure you watch the first part of the video so that it is very important you understand the anatomy related to this so that you can clearly understand the SONO anatomy as well. So as we have discussed there, the most lateral most muscle which you are seeing is the iliacus muscle. and the medial to iliacus we have the psoas muscle, and further medially we have the pectineus muscle. Pectineus muscle is not much of importance for us. Iliacus and psoas is the most important ones. And in the middle part of the psoas muscle, near to the iliopubic eminence, you can see this white hyperechoic round structure which is called as the psoas tendon. So this is very important to identify. So as we have discussed in the anatomy part, the articular branches of the femoral nerve, obturator nerve and the accessory obturator nerve are seen at the level in between the psoas tendon and the iliopubic eminence. So our target area is between the psoas tendon and the iliopubic eminence, where we have to reach our needle and we have to inject the local anesthetic. Few other important structures which you have to see as we have discussed in the anatomy part is superomedial to the psoas tendon and the muscle we have the femoral neurovascular structures. That is, from the lateral to medial side we have the femoral nerve, femoral artery and the femoral vein. So importance of identifying this structure is that when you are doing an in-plane technique, always use lateral to medial direction of the needle. Never do a medial to lateral direction of needle because you are going to injure these neurovascular structures. Same applies when you are doing an out of plane block as well. In out of plane block, you are safe to insert the needle in this specific lateral area. This middle area is a gray area where you may insert the needle if you are finding it difficult when you are doing in the lateral side. This medialmost area is where it is not advised to insert the needle in out of plane technique or if you are doing a landmark or PNS based block. Let's come to the technique of giving the block. So scan, as I have discussed earlier, scan the first mountain anterior superior iliac spine, come medially to anterior inferior iliac spine and then further medially until we see the iliopectineal eminence. Then I classically use a 23 gauge spinal needle. This is the spinal needle. We can remove the stillet and attach the connector here and start using it as any classic needle. Or else you can go ahead with a 10 cm Stimuplex needle or any echogenic needle or needle which you have available in your institution or area of practice. We will see an in-plane technique of giving the block, and in the end I will give a small description on how to give a landmark or PNS guided block. So in in-plane technique, we insert the needle almost 0.5 to 1 cm lateral to the marker on the probe. I have said earlier, in Peng block I always keep the probe in a way that the marker is on the lateral side. So insert the needle almost 0.5 to 1 cm away from the marker and direct the needle at 45-degree angle until you reach the target structure. So once you insert the needle, come at this point, that is at a point just lateral to the psoas tendon and just above the iliopubic eminence. Once you reach the iliopectineal eminence, you will feel the resistance, aspirate and inject the desired amount of local anesthetic. So once you inject the local anesthetic, you can see that the psoas tendon will start moving up. That is, it will move away from the iliopectineal eminence, and this is considered as one of the important signs for a successful block. Coming to the local anesthetic which we can use for giving the block, 20 to 30 ml of bupivacaine, levobupivacaine or ropivacaine in a concentration of 0.25% to 0.5% can be used, and you can use it with additive or without additive according to area of practice. Usually dexamethasone 4 to 8 mg or adrenaline 1 in 2 lakh can be used as an additive. Usually 20 to 30 ml is a described volume of drug. Large volume of drug is not advised to increase the success rate, because when you increase the amount of drug which is injected, there is more chance of the drug spreading into the medial side and involve the femoral nerve, as we have seen earlier. So it is very near to the area of interest, so femoral nerve may also get blocked and you will end up with the quadriceps weakness, which is not intended because you are giving Peng block as a motor sparing alternative. So restrict the volume of the local anesthetic to 20 to 30 ml. So once you have given the block, you need sufficient time for the block to act. It will take around 30 minutes for the block to act, and it will last for around 12 to 18 hours if you have added additives like dexamethasone. There are few studies which document the duration of up to 25 hours with added additive like dexamethasone. So when are you going to give the Peng block? We have already seen the indications for giving Peng block in the part 1 of the video. So for all these indications, you can give Peng block either as an on-arrival block, that is in the accident and emergency unit where the patient arrives and you can give the block as a pain relief until the further surgery plan is determined. Second option, you can give it just before the neuroaxial procedures so that you get adequate comfort for the patient for adequate positioning during the neuroaxial procedures. Or you can give it as an analgesic option along with general anesthesia, or it can be used as a postoperative analgesic option along with any type of anesthesia which you plan. Let's see the disadvantages and complications associated with Peng block. First one being, as you have seen in the anatomy, your block is not going to block the lateral femoral cutaneous nerve. So in that case, most of the proximal hip procedures like total hip replacement and proximal femur fixation, which involve the lateral thigh incision, that part cutaneous analgesia will not be covered. Definitely, if you give a large volume of drug in the Peng block, how you have got femoral nerve block as a side effect, lateral femoral cutaneous nerve may also get involved, but definitely it is not advised. So if you intend to give cutaneous analgesia, you have to give a separate lateral femoral cutaneous nerve block. Second thing, again, if the surgery involves incision on the lateral side of the thigh, especially if it is extending in the proximal part, even your lateral femoral cutaneous nerve of thigh block will not cover this area and you may have to give a subcostal or iliohypogastric nerve block. Third thing, the posteromedial compartment of the hip capsule may get supply from the sciatic nerve, and in which case you will not get complete analgesia from giving a Peng block, which is why Peng block is not advised as a sole regional anesthesia technique for any hip related procedures. Fourth disadvantage or complication which you can expect, as we have discussed, is the femoral nerve block and the associated quadriceps weakness. This happens mainly either if you are using a large volume of drug, or your area of injection is superficial to the psoas tendon, or if it is medial to the psoas tendon. So clearly from the anatomy, you know, if you are injecting in these two areas, there is a possibility that you may end up with a femoral nerve block. Fifth one, there is a possible injury of lateral femoral cutaneous nerve because the area of interest for needle insertion in the in-plane technique is almost same as the area where you can find the lateral femoral cutaneous nerve. So there is a theoretical possibility. Also, if you are going too medial to the psoas tendon, there is a possibility of injuring the pelvic part of ureter as well. These two are only theoretical possibilities because the Peng block doesn't have a large number of studies, and till now the studies have not demonstrated this specific complication. Let's see a few troubleshooting things and tips to improve your block success rate. First thing, use of a curvilinear low frequency probe will allow you to visualize the anatomical structures from a wider perspective of view. So you can clearly see the first mountain, then the second mountain coming, and then the iliopubic eminence coming. But at the same time, you will have a difficulty in visualizing the needle. If you are using a high frequency linear probe, you will have a better visualization of the needle, but at the same time it will be slightly difficult, especially for beginners, to clearly identify the anatomical structures. Second, if you are using a curvilinear probe, it is better to use a out of plane technique so that it will be very easy for you to visualize the entry of needle and reach that correct target area. And if you are using a high frequency linear probe, you can use a in plane technique so that you will be getting a better visualization of the needle as well. To know how to improve your needle visualization when doing a block, follow my 9 simple steps so that you can easily visualize the needle irrespective of the block type, irrespective of the needle size, irrespective of your experience in performing ultrasound guided blocks. I will give a link in the description. You can go and watch that video. It will help you definitely in a lot of circumstances, not only for blocks, it will also help in insertion of invasive access lines as well. So there is link in the description, please go and have a look. Then once you have reached the target area and when you are injecting your local anesthetic, if there is high resistance to injection, two possibilities are either you have hit the iliopubic eminence, that is why you are feeling resistance, in which case you can withdraw the needle few millimeters so that you will know that you have just come away from the iliopubic eminence and there the resistance will come down. Second possibility is you have gone into the psoas tendon, in which case again if you withdraw the needle out of the psoas tendon, the resistance will come down and then you can redirect the needle to the correct place. Another same possibility is that sometimes the piece of psoas tendon may get dislodged inside the needle, in which case Even if you withdraw the needle outside the tendon, there will be resistance, in which case you have to take out the needle flush and see the patency of the needle, and if needed you may have to change the needle as well. Last but not the least, always keep in mind that you have to restrict the volume of drug which you are giving for Peng block. Preferably less than 30 ml of drug is advised, especially to avoid complication associated with femoral nerve block and quadriceps weakness. Lastly, let's see a small description of landmark and PNS guided technique. This has been recently described in one of the articles. So in this technique, two important landmarks are, first is the anterior superior iliac spine, second one is the pubic tubercle. So you draw a line connecting these two lines. So at a point 5 cm medial from the anterior superior iliac spine, on this line is the area of interest. So you have to insert the needle perpendicular to the skin and direct deep so that you will go and hit the iliopubic eminence. And once you feel the resistance, you can give the drug. PNS guided technique is also the same. The difference from the PNS guided technique in Peng block compared to other PNS guided block is that here we are using the PNS guide so that you know that you are not in the femoral nerve area. So that will help you to avoid going near the femoral nerve and further femoral nerve block. So it is same as how you give a landmark based block from the anterior superior iliac spine 5 cm medial on a line joining anterior superior iliac spine and the pubic tubercle. When you are giving a landmark based technique or a PNS guided technique, always keep your hand on the femoral artery so that you know that your needle insertion point is far away from the femoral artery, at least 1 or 2 centimeters, so that you can avoid the femoral vein, artery and nerve from getting injured when you are doing these blocks. So that completes the video. So I hope I have given a good review on how to give a Peng block, the related anatomy, indications, contraindications, complications and disadvantages. So next time if you get a chance, go and give the block. It is a very simple block to give, and even someone with a beginner level of skill can easily give the block. So until we see next time with a new block, thank you.